I'm Robert Schertzer, Clinical Associate Professor at the University of British Columbia, Department of Ophthalmology and Visual Sciences, and Director of the West Coast Glaucoma Centre in Vancouver, BC, and we're talking about glaucoma with my guest, Marcelo Nicolela. In this episode, number 13, for early December 2010, we discuss glaucoma risk factors for development and progression of the disease. Please check the show notes of this podcast for definitions and references related to today's topic. The show notes also include contact information to find me on Twitter, where I'm Rob Schertzer, my glaucoma EMR tech and education blog, wholelotofrob.com, and my office website, westcoastglaucoma.com. Welcome, Marcelo.
Thanks, Rob.
So let's talk about glaucoma risk factors today. You presented that here at the meeting, and
okay, yes, we actually had a great session yesterday on risk factors, and what I presented was mostly trying to incorporate what we can do with all this new information that we have in glaucoma that accumulated really over the last 10 years or so. Most of this information is coming from randomized clinical trials, as well as population studies, particularly the ones that look at the incidence of new cases.
I guess we should talk about what we mean by risk factors in terms of risk for getting glaucoma, risk for progressing if you have glaucoma. And
yeah, that's absolutely true, and they might be different. Certainly, when we in the more epidemiological literature or way of thinking, if you talk about risk factors, you're really talking about risks of developing a disease, as opposed to prognostic factors, which would be related to risks of progressing or reaching an endpoint once you already have a disease. We use the term risk factors fairly loosely in the glaucoma literature, and usually when we refer to risk factors, we are talking about either factors to develop the disease or for progression of the disease. And in several instances, they are the same, but there might be cases where they might not be the same.
Right, and we'll talk a little bit about that in a moment, but also one thing we want to focus on by the end of this conversation is what we would do about it. So there's, I guess, little point in identifying certain risk factors if there's not something that's going to change our management of the patient.
Yep, you're absolutely right. And unfortunately, in most risk factors that we know in glaucoma are non-modifiable risk factors, such as age, race, there's family history, there's nothing you can do about those things. And the only really known modifiable risk factors that we have in glaucoma is really intraocular pressure. But we know a lot more about the effect of intraocular pressure in glaucoma onset as well as glaucoma progression than we knew 10, 15 years ago. Another point that might be interesting as well is even with the non-modifiable risk factors, it would be interesting to know if pressure reduction, once you have that risk factor, make a difference in your outcome, even though you can't modify that particular risk factor. But if you know that maybe treating more aggressively, once you have that set of factors, would change your outcome, that might be also very useful information. We are just really starting to get some data on that.
Yes.
So if we look at the information that was really collected over the last decade or so, a lot of that we already knew or we thought we knew, but certainly all the randomized trials as well as population studies have really defined for us that intraocular pressure is by far the most important risk factor for glaucoma. Even when you're dealing with patients with so-called normal tension glaucoma, the ones that have higher pressures in that group tend to do a little worse.
And even though if on any patient, if you're screening them, 50% of the time they won't have a high pressure. So it's a bit of a challenge, even though that's our most clearly identified modifiable risk factor.
Absolutely, and that's a great point. It's really it's almost a difficult thing to put in your mind that if you go out screening, at least 50%, in some studies even 60% of patients have what is considered normal pressure below 21. In one screening measurement, maybe if you measure the pressure several other times, the pressure would maybe go a little higher than that. But certainly intraocular pressure is the one risk factor, even in those with low pressure.
So let's take an approach of patients coming in to see a general ophthalmologist or optometrist. How should they be screened? What risk factors are being looked for as part of a screen?
Well, obviously intraocular pressure is one. The other ones that we already knew as well, or we've been known for a long time, is older age. The older you are, more likely to develop glaucoma or have glaucoma. Race, black race, and there's maybe now some evidence that the Latinos, at least the Latinos that live in the U.S., which come mostly from a Mexican background, seem to have a very high prevalence of glaucoma as well.
Right, that's the Los Angeles Latino study.
Right. Which really had a remarkable high prevalence of glaucoma, mimicking the ones that we see in black patients from West Africa or black descendants from West Africa, which is by far the highest prevalence in glaucoma, at least opening glaucoma ever reported. Other risk factors that are important are, and again, the term is being used very loosely, but things that probably are not really risk factors, but suggest that there might be early disease, such as suspicious optic disc or presence of an optic disc hemorrhage. Those things are obviously very important in terms of developing glaucoma later on.
That's one of my pet peeves with the OATS, the ocular hypertension study, where increased vertical cup-to-disc ratio was a risk factor. To me, that was likely already onset of disease.
Absolutely. The same in that study with optic disc hemorrhage is also a risk factor, and in follow-up. And it's obviously a very, it's a very loose use of the term risk factor, but because probably is early onset of disease, the same as increased PSD values on the visual field. Another, I think, very important risk factor that we learned a lot more about recently is the presence of pseudoexfoliation. We've always knew that pseudoexfoliation is strongly associated with glaucoma. But new information, particularly coming from the EMGT, suggests that the risk of progression of glaucoma in pseudoexfoliation is extremely high, even when they accounted for intraocular pressure levels. So it appears that there might be something else in pseudoexfoliation apart from the fact that they have higher pressures than open-angle glaucoma that we know.
Right. I found that very, very interesting, because normally I think of the main problem with pseudoexfoliation being that you never know what their pressure will be from one visit to the next. They could come in with their pressure of 50, but to find that it's a pressure-independent thing, just having pseudoexfoliation increases the risk of progression.
Yeah, that is a very interesting finding, and one caveat is, of course, that they haven't done diurnal tension curve in those patients. They were seen very frequently, every 3 months, but it's possible that their pressures are really fluctuating a lot during the day, and that wasn't measured. Right. But we also have to remember that in the inclusion criteria for that particular study, they excluded people with very high pressure. So they really excluded the pseudoexfoliations with pressures above 32, I think it was the upper limit. So you're really dealing with a group of pseudoexfoliation that have pressures in the slightly high upper end, and they did significantly worse than the primary open-angle glaucomas with similar levels of intraocular pressure, who actually did significantly worse than the so-called normal tension glaucoma in that study.
Right. Yeah. And it's a good thing they did exclude patients with those really high pressures, because the control group was non-treated patients.
Yes. That's precisely the reason why they had to. Yes. So other risk factors that are less clear, or there's a lot. One other very important risk factor that became apparent in the last few years and extremely important in onset of the disease, as well as likely progression of the disease, is low perfusion pressure or low blood pressure, if we will. Perfusion pressure is really calculated by brachial blood pressure, less intraocular pressure. But several, even the first study that I remember that showed this relationship between low perfusion pressure and glaucoma was the Baltimore Eye Survey. But that was confirmed very clear in the Barbados study now, as well as the early manifest glaucoma trial, that low perfusion pressure is related to glaucoma development as well as glaucoma progression. Again, there might be...
So that's possibly a modifiable risk factor.
Possibly, yes. Yeah, we have to fight with the cardiologists, though, because they like low blood pressure, and we apparently don't. So that's something that if you talk to your cardiologist colleagues about those findings, they really try to dismiss them, because the cardiologist literature has been pushing more and more for lower levels of blood pressure.
Just like we are for the eye pressure.
Exactly.
So similar battle. But at least there's some flexibility, because we could propose that if it's a patient that's on antihypertensives for their blood pressure, that the dosage could be at a different time of day, so they're not getting their maximal drop in blood pressure when they're sleeping, which is when we're assuming most of the problems occurring with the glaucoma.
With glaucoma, yeah.
So we have our patient here. All those factors are taken into account. So where do we go from there in terms of how we use these risk factors on a practical basis?
Yeah, it's I think we still have to obviously look at every patient individually, but you at least we know more what a priori would be the risk of that individual from either developing glaucoma or showing significant progression. So if you have somebody in front of you that comes with... Did
we mention pachymetry, corneal thickness, in that mix? I guess that's another one to add to the list.
Yeah, obviously I don't have a list here in front of me, but well said. Pachymetry is another risk factor that really we didn't have it until OATS came along, and there's been now confirmation from population studies as well that pachymetry is certainly related to the progression from ocular hypertension to primary open-angle glaucoma, and quite likely related to the development of glaucoma, even if you're not dealing with a strictly ocular hypertensive population. That comes from the Barbados study.
Are all these population studies with, I guess, non-white races? Do those people all have thinner corneas as well? I mean, it is the case for the African population. I think it's the case for the Mexican population too. Also,
the Mexican population, yes,
thinner.
Yeah, the Latinos' average central corneal thickness was, if I remember correctly, was in between the average corneal thickness for blacks and whites, but closer to the one you see in the black population. So,
and still, for our audience to point out that that is also pressure independent as a risk factor. It's not a correction factor for their intraocular pressure. Just the corneal thickness alone is an independent risk factor.
Yeah, that seems to be the evidence. And we really don't understand why that would be, if it's really giving us any indication of other elastic properties of the whole eyeball wall that might be related to glaucoma, amount of the way the lamina cribrosa might resist, might deal with stress. So we really don't know what the reason is for that. Certainly, if you're asking me earlier, I mean, what do we do once we have the patient in front of us? And as I mentioned, I think we know a lot more. First of all, I think we would do a corneal pachymetry, which we wouldn't be doing some time ago. We certainly would pay a lot of attention to whether the patient has an optic disc hemorrhage or not, because that confers a very high risk of converting to glaucoma or progressing to a more significant stage of the disease. And we are going to investigate the non-modifiable risk factors that might be important. Certainly, look for family history. I mean, family history to me is particularly important if you have some information of what kind of glaucoma the relatives had.
Right.
If they
if they all had onset less than 40 years of age, then that's a big red flag.
Yes, absolutely. Like, and if they required surgery, obviously if they went blind. But we see in clinic as well the other side of the coin. A lot of people tell me, "Oh yes, my parents or siblings have glaucoma." And then when you start asking about it, you really feel that probably they might have had a very mild glaucoma or ocular hypertension and were treated, and that to me probably is not a significant risk factor for that particular individual. So it's important to try to really understand a little bit what this family history actually is. One thing that I particularly haven't incorporated in my practice, but maybe we should, is measuring blood pressure in every patient coming to the office. I don't know if you do that, Robert.
The only patients who I measure blood pressure on, I actually send for a diurnal blood pressure measurement if they seem to be progressing and their eye pressures are normal or low.
Yep.
Then they'll get a 24-hour blood pressure monitoring and see if that mean diastolic pressure is dropping to like 40 or less when they're sleeping.
Yeah.
But otherwise I don't.
Yeah, that's something I do as well. But maybe we should be, that would be an easy thing to do, incorporate in the practice. Just get the blood pressure measurement early on, and calculate their perfusion pressure. I don't think we'll do much with that information from the beginning, but it might help us understand why some people seem to be, developing glaucoma faster or showing some different behavior of the disease. It seems to me another factor we haven't mentioned is gender, and I think that's an interesting one because the results are a bit controversial. If you look at a variety of different studies, population studies, very well done, it tends to suggest that there's a slightly higher prevalence of glaucoma in males than females, and if you do a meta-analysis, that's what comes out. It turns out that the intraocular pressure is also slightly higher in males than females if you do a meta-analysis of all those population surveys. But whether...
but in the normal attention glaucoma study, there was females who were at higher risk than males.
For progressing, exactly. Yeah.
Right.
So that's interesting. If you look at now at the randomized clinical trials that looked at gender, or at least reported on gender factors, the normal attention glaucoma study clearly showed that females were more likely to progress. And interesting, the Canadian glaucoma study, which was recently published a year ago, and by the way, that study didn't have an untreated arm like the normal attention glaucoma study, but that also showed that females were more likely to progress. In that Canadian glaucoma study, there was a large proportion of patients that would fit this normal tension category of glaucoma. I mean, there's a large proportion of patients that didn't have a history of elevated intraocular pressures. On the other hand, the early manifest glaucoma trial, which was basically done in Sweden, there might be a difference in racial background, did not show any gender preference for progression. So I think the data is still controversial, but if I have a patient with glaucoma with relatively normal pressures, I tend to look at them slightly different if it's a female patient as opposed to a male patient, and particularly if it's a female patient with suggestions of vasospastic disease, which is again another controversial risk factor. But I tend to believe that those people are a little more likely to progress than males on the same pressure category. Yeah.
So now let's say you have a patient and they have all these risk factors. Let's say thin corneas, pressures, mid-20s, let's say, family history of glaucoma. Do you treat them or do you follow them? If their visual field and optic nerve seem to be optic nerve imaging or
seem to be normal.
Yeah.
Okay. Yeah, I think there is, in my view, no right or wrong answer there, and I think that's something that we really need to, discuss with patients if you are, dealing with that, glaucoma suspect category. In this case, somebody with an elevated intraocular pressure. And it's interesting when we discuss with patients, at least when I do, I get all kinds of responses. I mean, I have patients who, are dying to be treated because maybe of the family history, they saw what happened to their parents.
Yeah, same here.
Yeah. Others that you really want to treat them because their pressures are, more than you would feel comfortable just watching, and
they don't want to be treated.
And they don't want to be treated. So, and you have to respect what what patients really want, and certainly I think there's two points to consider there. Once you have your risk factors and you say, I think you have overall, low, medium, or high risk. I would probably be, in most cases, offering treatment for their high-risk group, but offering, not pushing treatment.
Right.
I mean, if they don't want to, that's fine. But I will certainly offer, greater surveillance and closer follow-up for the medium to high-risk group,
right.
And less so for the low-risk group.
Right. I tend to basically tell them the number that you could see if you take that Oates study graph. And say, okay, it's showing 12% chance of glaucoma in the next 5 years. See how they feel about that, whether they want to be treated or not. And I explain that we really need to follow you. And I add, if there's a good chance you won't be coming back and regularly for your visits, then it's even more important that you get treated. But then again, they're also more likely to not comply to the treatment. So
exactly, those are the ones
tough.
that will be very hard. The ones that don't want to come back in the first place. Yes.
Yep.
Yeah. Another, and I must say, in several cases, in the initial visit, you attribute a medium to low risk to a patient, and it
right.
turns out that the patient progressed quite significantly, and vice versa. Right. So you really can't.
There's no way to predict
tell
how fast someone will progress. There really isn't. We have population studies that group as a population together chance of progression, but no way to tell an individual's risk of progression.
Absolutely, yes, and that is really another probably very important new or at least something that we probably all knew from before, is that patients with glaucoma behave quite differently. Even if you look at the progressive patients from the normotension data or the early manifest glaucoma trial, their rate of progression is extremely variable. So some might actually progress incredibly fast, and those are the ones you certainly want to catch
right.
early and treat aggressively. But others can, progress, but at such a slow rate that probably
won't progress significantly in their lifetime.
Yeah.
Yeah. Well, maybe one day we'll be able to tell, have customized answers for an individual regarding their risk of progression. And that'll be helpful, but we're certainly not there right now.
We are not there right now, and I think I am not sure we'll be able to predict with great accuracy what's going to happen, because it's I think it's a long stretch, but we certainly know more than we used to, and I think we have a better, I think less of a pre-established cookbook approach to glaucoma treatments. I think now we vary where we want to be depending on all those factors that we know, and I think it's a step towards individualized treatment, which I think it's important in glaucoma.
Yeah. Great. Thanks so much.
Thank you, Rob.
That's our show for today. Be sure to subscribe via iTunes. Simply search glaucoma or Schertzer and you'll easily find it. Or subscribe to the RSS feed so you won't miss an episode. Follow me on Twitter to learn more about upcoming episodes and other news about glaucoma, electronic medical records, technology, healthcare, and education. And visit wholelotofrob.com and westcoastglaucoma.com. If you have a moment to post a review on iTunes, it would be most appreciated. I produce Talking About Glaucoma without any technical or financial support, approximately once each month or as time permits. The AAC format is the enhanced version that includes chapter markers and show notes. The mp3 format just has the audio. If listening from your computer on my blog, website, or iTunes, or from an iPod or iPhone, and most other portable devices, the enhanced version is the better choice, so try it first. Once again, on Twitter, I am Rob Schertzer. My blog is wholelotofrob.com, and my website, westcoastglaucoma.com. Look for me everywhere. Drop me a line at podcast@iguy.org. That's IGUY.org. And rate the show on iTunes. Please help detect and treat glaucoma by keeping yourself informed.